All right. So uh, this morning we're going to continue our lecture into respiratory system with the mechanics of breathing, and this is going to include the pressure relationships within the thoracic cavity. But before I go on, we do have uh, a lecture quiz today. Lecture quiz will open at 9:45. So I'm going to type that in. So it starts at 9:45, and it's in module 10 at the top for everybody. And the quiz runs until 10 a.m. So you have 15 minutes. And again, the format is the same, true false, multiple choice, as it has been. No extra credit. It's just a 15-point quiz. All right. So respiratory system with a bit of the physiology. Inspiration, we're talking about atmospheric gas flowing into the lungs. Expiration, all the gases that you've created are going to exit the lungs. And this is primarily carbon dioxide coming out of you. Atmospheric pressure is the pressure exerted by the air surrounding the body. At sea level, where we live here, it's 760 millimeters of mercury. You don't have to know how that measurement has come about, but that is the measurement, that is the pressure. Uh, Best to think of it as that we live under an ocean. It's an ocean of air, and this air has weight, and so it exerts a pressure, and that's the numerical value of that pressure here. We predicate our ability to breathe in and out based on this pressure. We predicate our ability to breathe by our ability to change the volume of the thoracic cavity so that we change pressure within ourselves. So our ability to breathe is because our musculature surrounding the thoracic cavity is able to contract in such a way that we can expand and contract our thoracic cavity. And we use this by movement of the ribs. So by moving the rib cage, we're able to make these changes. You can best, demonstrate this on your own person so that when you take a deep breath, your chest naturally expands. It gets bigger in order to facilitate good breathing and ventilation thereof. It's best to have an upright posture, sit up as straight as you can, or walk as tall, or run as straight as you can, keeping a good erect posture. And this facilitates your ability to maximize the expansion of your thoracic cavity to get lungs full of air. Anything that compromises this compromises your ability to bring atmospheric gas into your lungs, and therefore is going to compromise your ability for perfusion of oxygen into your system, and you will suffer effects of hypoxia. That term hypoxia is a compromise of oxygenation, hypoxia. So I'll type that here, hypoxia. 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 So that's a term perhaps you need to learn. come up with. All right. So we're going to be working with this through the lecture. So yes, this is an important value for you to memorize. So here we have our lungs. Here we have our trachea. Here's our carina, the bifurcation into the left and right bronchi. And then we continue, and it doesn't show exhaustive branching, but it gives you an idea. Here's our lungs in the pink, pleural cavity. We have our visceral pleura, which is the deepest, the parietal pleura, which is the most superficial. And remember, between the two pleura is a small space where we have a fluid, a lubricating fluid. The thoracic wall here on the outside. Now, in the thoracic wall will be the ribs and the intercostal musculature. The intercostals, we have two, internal and external intercostals, and these have to contract and relax, and they help in moving the thoracic cavity so that we get expansion and we get uh, depression of it. At the base of the lungs is the diaphragm here. These pressures that you see here are just showing uh, pulmonary pressures. Those you don't have to learn, or the intrapleural pressure. We're going to be mostly concerned with the pressure changes in the lung itself. So this is showing a type of trauma where there is a puncture to the cavity. Now, anytime that there is a puncture, there's going to be a compromise in the pressure within the thoracic cavity. And this is why any type of traumatic puncture to it is going to compromise your ability to breathe and can lead to a collapsed lung. And there's a term for that, pneumothorax. Pneumothorax. That's where you have a loss of the pressure, you have a loss of the integrity within the cavity because of this. We'll get back to atelectasis. Pneumothorax then is air in the pleural cavity. When it's healed and they repair it, the lung is able to reinflate, and then your capacity to breathe normally is then replaced. Because when the lung collapses, the alveoli will collapse, and so they can't fill with air. So volume changes are going to lead to the pressure changes, all right? Boyle's law, you don't have to learn that here for anatomy, but this is something you will be required to learn in physio, so just kind of keep that somewhere in the back of your head. All right, so inspiration is the active process involving the inspiratory muscles. I've already mentioned the intercostals, and I've made mention of the diaphragm, but we have additional muscles which we'll talk about. The diaphragm, when you breathe in, flattens, flattens out, and it pushes down your viscera inferiorly. And by breathing in, you are expanding the pressure. I mean, you're expanding the volume. So you are increasing the volume as you breathe in. And we'll talk about the pressure change momentarily. And the action of the intercostal muscles Well, it's going to lift the ribs up and out, much like a handle on a bucket. You don't have to really memorize that either, but you do have to know that we get an expansion. And this diagram shows you here the expansion. So here we have breathing in, inspiration, and here we have breathing out, expiration. So here these arrows are showing the elevation of the thoracic cavity, the chest wall. Here's our sternum, our manubrium. Here's our intercostals. Oh, and by the way, intercostals are what you actually eat when you have ribs. So when you have barbecue ribs or short ribs, those are the ribs from the animal, whether it's beef ribs or pork ribs. And you can appreciate, you know, how really big a cow is when you have beef ribs to eat because the bones for that are pretty big. Expiration, we see here, the ribs in the sternum are depressed. As the muscles relax, the diaphragm too will relax and push upwards into the thoracic cavity. And this is going to decrease the volume. So here we have an increase in inspiration of the volume. So think of inspiration with the I with increase of the volume. Expiration, we're going to decrease that volume. All right. So there we've got volume changes with this. Additional muscles, accessory muscles, are the scalenes, the sternocleidomastoid, pectoralis minor, also the erector spinae muscles of the back. These are muscles that run along the posterior of the thoracic cavity. So that's why having a good erect posture facilitates good ventilation. And again, anything that compromises this, like if you're sitting and you're sort of slumped over, this will compromise the ability to change the volume. Being overweight will also compromise this ability because you have all this weight in the chest on your body and it pushes down on you. It makes it difficult to get that volume change for ventilation. Uh, there's a term for this brought on by obesity, and it's called Pickwickian syndrome. And it comes from the novel The Pickwick Papers by Charles Dickens, where it was first described when there was a very fat character who seemed to just sort of fall asleep every time they sat down because by compromising the ability to ventilate, you're also compromising the amount of oxygenation to the blood and therefore oxygenation to the brain. So when that occurs, the brain will begin to shut down. And so one of the things it takes away is, of course, consciousness. And so they just sort of fall asleep. We'll talk about COPD in a bit. All right. So quiet expiration is a passive process because it doesn't really take much to breathe out. You just relax, okay, and let it go. Breathing in, breathing out. These don't take much thought. You don't have to think to breathe in and to breathe out. None of us do. It's all done normally. Now, under emotional duress and physical duress, you have to remember to breathe. This includes working out. So if you're doing any types of squats as a repetition in a set, you have to be able to breathe. You have to be able to ventilate. And this is why trainers are always, watching your client to tell them, okay, so breathe in at this point, exhale at this point. So you're going to breathe in and you're going to breathe out. Otherwise, some people just keep going and they hold their breath and they kind of bore through it, and all of a sudden you get really lightheaded. And this is one of the reasons why some guys get really lightheaded, some women too, because you're not breathing properly in completing these exercises and doing these exercises. So some of you might be going into type of training and everything. So this is one thing, a very basic thing you have to watch in your clients. Um, in pregnant women, all right, when they're in birth and the birthing process, of course, they have a coach, they have somebody there that is reminding them to breathe in, breathe out, because of the pain and the duress of the birthing process kind of robs them of their ability even just to breathe well. So, as humans, we sometimes need that reminder. All right, let's see. Non respiratory air movements, examples of these are coughing, sneezing, crying, laughing, hiccups, and yawns. Most are from a reflex action, although some are voluntary, such as laughing. Okay. Sneezing, of course, is involuntary. No one can make a good sneeze, it just sort of happens to you. Um, And we talked about hiccups when I mentioned that that is a spasm of the diaphragm. Notably, it is a spasm of the skeletal muscle, and sometimes that's brought on by the phrenic nerve. All right. Now, each alveolus is a small balloon, and it has a lot of surface tension to it. And I mentioned that this surface tension is relieved by the existence of a substance called surfactant. And that's when I told you surfactant was palmitoyl lecithin. Dipalmitoyl lecithin. And that you begin making this a couple of weeks before birth and you continue to make it throughout your life. Indeed, you have a specialized cell that's cuboidal shaped within the alveoli that create this. A premature baby doesn't have this being made. And so, this is why if they're born prematurely, they're going to have a compromise because by decreasing that surface tension, it helps to keep the alveoli expanded easier. Without it, each breath is like the first, and that's a big struggle. So, again, surfactant prevents alveolar collapse by reducing surface tension. Insufficient quantity is called infant respiratory distress syndrome or ERDS. The old name for it was hyaline membrane disease of the newborn. So again, common in the premature. All right, so now they make artificial and then they have mechanical ventilation to help the babies along until they began making their own. So now, as a side note, as you develop, you practice breathing even before you're born. In the womb, baby is practicing breathing. And what are they breathing? There's no air in the womb. So what are they breathing in and out? of their lungs. What are they moving in and out of those alveoli? They're moving amniotic fluid. And what is amniotic fluid? Amniotic fluid supports the baby, but where does it come from? Well, amniotic fluid is baby pee. So the kidneys are online and the baby is peeing and it's peeing into the fluid and it's breathing this in and out. So if there is a compromise in the volume of amniotic fluid, that means there's a compromise in the renal function of that baby. So this is why it's important for good prenatal health to go to your regular appointments, ladies, uh, to make sure the volume of amniotic fluid is good, movements of the baby are good, etc. Now, at birth, you have to get rid of all that fluid within the lungs that's collected. And so the old practice that even is today, when children are born for most people, and they talk about, oh, well, birthing should be a really gentle process, welcoming the baby. And that's true. It should be welcoming the baby, but birth is not a gentle process for the baby or the mother on any level physically. So when the baby is born, we got to get rid of that liquid in the lungs. And so this is why before they used to invert the baby. A doctor would hold it up by the ankles so the fluid is like draining out. Now they use a suction that helps kind of suck things out of the lungs. But they would drain it that way, smack the backside. This causes indignation in the baby. Now, the baby's upset because it's now exposed to air. It's never been around air. What is air? What am I supposed to do with this? Where'd all the liquid go? And so now the liquid's draining away and the baby's upset. So a natural thing, and this is all governed in the brainstem, is to take in air, you know, and the baby cries. Wah! And this is why we want to hear a good, strong cry in the birthing chamber. This means that the baby is evacuating all that fluid out of its lungs so that now it can begin the process of living in the world and exchanging gas so that it can oxygenate. Prior to now, the baby did not derive oxygen from the amniotic fluid, but it got its oxygen from the cord blood through the umbilical cord. We'll talk more about this when we get into development and reproduction. So we develop moving fluid in and out of our lungs. Now, if our oceans were oxygenated richly and there was no pollution created by man, and we didn't have the toxics that we have in our ocean, and our world was different, meaning that it would be warmer, theoretically, you could go up to the ocean, immerse your head, and start taking in liquid and moving it in and out. Now, that's not a normal thing to do because we know that you take in liquid, you're going to drown because you've got all that liquid. Well, why do you drown? Well, it's because of hypoxia. You can't exchange gas because the ocean water isn't rich in oxygen. But let's say that it was a completely different mix. Theoretically, you could then go into the ocean without any breathing gear and live underwater. You could walk from here to Hawaii. You could take a hiking trip from here to Asia or all over the world because of doing this. Now you might be like, no, that's really far-fetched. That won't happen. But it does. We do have jobs, deep sea diving. Some deep sea divers, they put on suits, and within the suit, instead of air, it's replaced around the head with hyperoxygenated fluid. And so these men and women put on these suits and purposely drown themselves in this fluid, and then they're able to go underwater and work at greater depths and pressure, and they're able to breathe this fluid in and out and work for short periods of time, maybe 1 to 3 to 6 hours. It just depends, on the oxygen content of the fluid. The difficulty is when they come out and they take off the suit, because now you have to kind of throw up that fluid out of your lungs. And so the recovery period, of course, takes some doing. And so this is why there's a very high rate of pay for this type of a job, because you're kind of traumatizing your body every time you do it. But it is possible, and it's possible because that's how humans develop. All right. Now, uh, inflammation caused by tuberculosis. Okay, so what is tuberculosis? All right, I'll get back to these other interesting things. Let me get to the pressure changes. Here we go. All right, so total atmospheric pressure, 760 millimeters of oxygen. Oh, I see a student has their hand raised. Okay, someone have a question? You want to type it in, or you want to articulate it? No? Okay. All right. All right. Now, first, we have to consider that the respiratory membranes are very thin, from only half to 1 micrometer in thickness. Okay, so remember, it's only two cell membranes thick for this exchange. And of course, the exchange for gas is by diffusion. Diffusion. All right, we talked about pneumonia, and we continue on. All right, to some of the changes here. Let's see. Oop, I'm not done yet. Let me go back here. All right, so let me get back to this picture. All right, so in addition to the volume change, we have a pressure change. So again, standard pressure, 760. Now, in order to breathe in, we've changed the volume, as I said. So to breathe air in, we increase the volume. So increase the volume, decreases pressure. Write that down. An increase of volume decreases the pressure. And it decreases the pressure to 758. 758. That's the change, just 2 millimeters of mercury. Pressure change, 2 millimeters of mercury. So by increasing the volume, we decrease the pressure. By decreasing volume, guess what? We increase the pressure. By decreasing the volume, we increase the pressure. What do we increase the pressure to? Well, we change that pressure within our thoracic cavity to 762. So again, it's a 2 millimeter mercury change. So that's all you have to change within your thoracic cavity to get good inspiration and to get good expiration. Just that little change. Anything that compromises that is going to compromise your ability to change. This is why we can't breathe in a vacuum. What is a vacuum? All right, a vacuum is when we've evacuated all of the atmospheric gas from a chamber. A perfect vacuum exists in where? Outer space. And so that's why you can't breathe in outer space. First, there's no oxygen present because it's a vacuum. So you can't affect movement if there's nothing there. Okay. And in fact, by changing, just 2 millimeters, you still have 758 millimeters of mercury inside of you. You're pressurized on the inside. So if you were placed in a zero pressure environment, guess what? You would start exploding from the inside out. You would hemorrhage terribly, bruising. Your lungs would become a unusable froth if you live that long because the oxygen on your blood cells would start to leave at an unprecedented rate, and the microscopic event is very much like that of shaking a bottle of soda before you opened it. You know what happens with that? It sprays all over the place. Okay. Well, this explains that condition called the bends, like when a diver comes up too fast from the ocean, the pressure hasn't been balanced well, and so the oxygen begin to bubble off of the hemoglobin, and this is of course lethal because there's nothing that can really be done to fix it in the past. Now we have hyperbaric chambers. Hyperbaric chambers. So hyperbaric chambers. And there's a whole field of medicine that goes with this. You can specialize in hyperbaric medicine as a nurse. And I have met these individuals because they used to have a hyperbaric chamber at Western Medical Center when I worked there back in the day. I don't know if it still exists. I do know that they do have one at Hoag, and they do use it for wound healing and recovery and things like that. But it's also used for like guys and girls that are suffering or potentially have the bends if they've been diving and they put them into these chambers, repressurize, and then slowly change the pressure so that they don't suffer from the effects of the bends. In the past, they would get this and it would be lethal. Now there's a way to treat it if the person's gotten to in time. Now, to become a hyperbaric nurse, of course, there's all sorts of certification and everything that goes with it, but it's one of the highest rates of pay. And your job is to monitor the patient as they go through these changes. So you have a lot of responsibility on your hands, keeping an eye on these people while they're within this big chamber undergoing this process. So, and if you work on holidays, oh my gosh, I mean, really, they made bank. So that might be a branch of medicine some of you might like to explore, hyperbaric medicine. Anyway, pressure changes. So increase of volume decreases the pressure. A decrease of the volume will increase the pressure. Yes, you will be asked this not only on your next quiz, there might be a question, maybe two, no more, and again on your final exam with this. And again, you're going to review all this. This is the anatomy behind breathing, and you're going to get into the physio again when you do take physiology with this. So, any questions? Okay. All right. So, we've gone through all of that. So, let's get back to tuberculosis. What is tuberculosis? Tuberculosis is a bacterial infection. So, you get infected by this bacteria, it gets into your lungs, and it'll cause problems. Uh, they x ray for tuberculosis. All right. Now, how do you x ray for a soft tissue infection? Because x rays only are supposed to pick up calcified and hardened things or foreign objects that would be dense. How do you develop a density uh, to an infection in this way? So, how can you x ray a person and look at their lungs in the x ray and say, oh, gee, they have a really bad tubercular infection? Well, the body, in an effort to control and contain the infection, is smart. And so, once you start forming fibrosis, once you have fibrosis, and this is a uh, turning on of fibroblasts that begin to make scar tissue, this the body wants to contain. So it begins to create a shell of calcium. And it's this calcium shell that they see on an x ray. And so this is why, in addition to blood work, etc., one of the most reliable ways to diagnose tuberculosis back in the day were these x-rays because your lungs would light up. Now, if it was only one or two spots, well, they could treat it. Uh, and today they treat it with antibiotics. Back in the day, before they had antibiotics, if you didn't know, antibiotics didn't come online and weren't really invented until after the 1940s, after the Second World War. So it was in the late 40s, and really it was in the 1950s that antibiotic pills and injections were given to treat all kinds of infection. Well, it was like a miracle cure for tuberculosis because back in the day, tuberculosis was like their AIDS, no cure. That was going to take you out. And it eventually took you out because the old term for tuberculosis was consumption. And this is something I want you to know, consumption, because it looked like the person was being consumed by something on the inside. Now, to be sure, calcium shell creation is not exclusive to the presence of infection, but it's also seen in long-standing foreign bodies within the body, notably breast prosthetics. And this is why breast prosthetics become hard when a woman goes in and they have breast prosthetics put in and the result looks really good. Well, over time, and especially with the silicone ones, the body would form a calcium shell around the prosthetic, and it would become hardened. And I have seen this. And if that shell become broken, the potential for puncturing the prosthetic exists. And then you begin to get leakage of that silicone out of the prosthetic, and that silicone goes everywhere. It travels throughout the body. And so you can't really get rid of it. And then it's going to cause all kinds of problems because it poisons the individual because of it. All right. So anybody have any questions? Somebody said they had a question. They had a hand raised, but I didn't hear back from them. So, okay. All right. Certain pulmonary diseases reduce alveolar surface area. For example, in emphysema. Emphysema is where we get a breakdown of the alveoli and the alveolar chambers. So rather than have these millions of little alveoli, now we form these big blisters, and pathologically, they called these blisters a bleb. I know that doesn't sound real clinical, but yes, they're called blebs. And so you form these blebs on the surface of the lung, and this compromises gas exchange. So, see, here we have a normal section of the lung showing the alveolar intact, beautiful. Here we have a really damaged lung tissue. We see a loss of the architecture of the alveoli into larger and larger chambers where gas exchange will not occur. And so this is why emphysema isn't really uh, curable. What they can do, and they had pioneered this actually in surgical practice at Chapman University Hospital, I believe, they began removing blebs. And so by removing these blisters from the lungs, it created a little more volume in the space in the lungs and allowed individual alveoli that were healthy, that remained, to expand and kind of take over. And so I've seen that too in the pathology lab when they remove these, and they can be quite large. I mean, they do look like a balloon of tissue that comes off of the patient. You can see that anything, again, just by looking at this photomicrograph, that fills the alveolus is going to compromise gas exchange. And so that's why there's all these respiratory problems. And so, let's see, compromises the perfusion. All right. Atelectasis, I'm looking at the pulmonary problems at the bottom. Atelectasis is when there's a blockage of a uh, breathing tube of one of the bronchioles. So that's what atelectasis is. Blockage of a tube. So it could be the bronchus, it could be one of the tertiary bronchioles, whatever. And by blocking off one of those tubes, you're going to reduce the pressure and get a partial collapse um, of that particular segment because there's additional segments in addition to the lobes of the lungs. You don't have to learn the multiple segments, but that's what atelectasis is. Asthma, asthma is a spasm of the smooth muscle that surrounds the trachea and surrounds the primary bronchi and down on in. It isn't a compromise. It is not a compromise of the hyaline cartilage, but of the smooth muscle layer. surrounding because you have a smooth muscle layer on the trachea and on the bronchioles especially, so that in an asthma attack it collapses, and so this decreases the lumen of the bronchioles and then therefore compromises the the not the perfusion but the passage of gas, and it makes it difficult to breathe. And so that's why in an asthma attack you can't ventilate well. Now asthma can be brought along, can be brought on by infection, like a fungal infection in the lungs. An asthmatic episode can also be brought on by emotional duress, stress. Person has that problem breathing. It can be triggered by something you breathe in the air, like the ash, for example, when we have local forest fires. And this is why people have difficulty breathing when there's a forest fire and there's a lot of ash in the air. I mean, you can tell by looking out. Sometimes I've seen at the college parking lot, there's so much ash because we're close by where the fires are that it looks like somebody dumped an ashtray all over the parking lot. It's a fine layer of ash on the cars, on the asphalt, and that's getting in the lungs. That's getting deep inside, and that's kind of shutting down your ability to breathe all that in. And so this is supposed to help you survive being in something like that, but not really if you can't breathe too well. So anything that comes in, anything that can compromise this is going to cause you problems. Extreme laughter. Like if you're laughing really hard, I mean, you're laughing to the point where you can't breathe. And if you can't do that, that also is an asthmatic, a transitory asthmatic condition. And so all you have to do is relax, and you catch your breath, and then you can go on with it. Some of you might be sitting there saying, I have never laughed until I can't breathe. Oh, well, then you have something really wonderful and kind of distressing to experience in your life still. I highly recommend it, not not on a daily basis, but I do recommend finding somehow to laugh till you can't breathe, and then relax and stop it. It's a very interesting sensation. Now, going back up to the neural control on the outline of the pons and the medulla oblongata, you can't hold your breath until you die because you have a respiratory group called the dorsal respiratory group in the respiratory center that excites the intercostals and the diaphragm and is going to force you to breathe normally. So, yeah, you do have some people, well, children, small people, who try this, to get their way, and it just doesn't happen, and it can happen to the point where a child can pass out or become dizzy and just sort of sit there kind of dazed, but then they'll recover and kind of look around and stop their crying and realize, okay, that didn't get the result from mom or dad that I wanted to, so I'm not going to do that again, type of thing. So, yeah, if you have a child that's given to fits or tantrums and they hold their breath, just stand back, watch what happens. They'll come back and it'll be okay. So, this notably happens during the terrible twos uh, of a small child. All right. Any questions? Okay. Well, then that's all I have for today. So get ready, and you will have the quiz opening up at 9:45. There's one person. It's going to open up a little earlier, but that's a different testing situation altogether. Everybody else listening to me, it's at the top of module 10, and we will See you in lab. Yes, we do have labs. So make sure you guys come prepared with your gloves and goggles and a lab coat, wearing old clothes, closed-toed shoes, because we do have a dissection exercise today of the sheep brain. So, all right. Group one meets in lab today. I believe it's group one. Whatever your calendar says. I don't have my calendar handy real quick, so hold on. Let me check real quick for you guys.
Professor, I have a question.
Okay, I'm listening.
That sensation that you were talking about where you laugh until you're out of breath, is that similar to when you're like gas when you're winded from exercise or from just speed walking or any of that?
No, that's totally different. In that instance, it's because you have used all the oxygen because of physical exercise and physical demand. I don't know if I mentioned it, but I'll say it here that when you have excessive exercise and you put a lot of demand, your spleen is like a blood reservoir for you. And so that's why when you are in high physical mode, you develop what's called a runner's stitch or a swimmer's stitch. You get that real sharp stabbing pain on your left side. Well, that's because your body has squeezed the smooth muscle capsule surrounding the spleen, and this is going to eject that volume of blood from your spleen into your circulation. And so within 5 minutes at the most, it's usually a minute, that pain goes away, but then you get your second wind. Well, what's that second wind? It's an increased volume of blood that's now allowing you to carry more oxygen and recover better. So that's why athletes who train know that once they hit that runner's stitch or that sharp pain in the side, I mean, it's really sharp. You almost feel like, oh, you kind of double over just a little bit. But once they work through that, they do a lot better. Their performance kicks up another notch for them. That's what that is. Good question. All right, so let me check my calendar real quick here. So as I look, anybody else with another question? I'm listening as I check. Okay.
Professor, we need a dissection kit as well, correct?
You do. And we do have a few instruments in the lab, but they're older, they're not sharp, and it's not like we have enough for everybody. We do have quite a few, but you're going to definitely need it when we get to the sheep brain and the cow eye. So let me see. All right, so what I'm going to do here is collapse that. And I'm looking here. Yes, group one meets today. It meets all week. Group one. Group two is online nervous system. So, all right. Anybody else? And I'm looking at chat screen. Let's see. Okay, everyone's asked. All right, so you're doing good. Okay, we'll see you later. Get ready for your quiz. Talk to you soon. The lecture is posted from Monday already. So if someone says, "Can I post the lecture from?" It's been up. It was up Monday morning. I put it up at 11 a.m. when it came through. All right. Take care, all. We'll see you soon.